My name is Dr. Eric Makhni. I'm a board certified orthopedic surgeon with 20 years of research experience and 15 years of surgical experience. In that time, I've published 170 peer reviewed publications, three textbooks, including one dedicated to value based care, and have started a digital health company focused on helping health plans lower their MSK cost of care through high quality, multidisciplinary digital approach. Today, I'm going to teach you what I know about the MSK money pit and how you, as a health plan, can avoid it. So the first thing we need to talk about is why MSK costs are always high. And there's really three factors, and we'll go each of them. One, first of all, disease prevalence is high. 1 in 2 adults have some sort of back, neck, or joint pain, and that is a problem and obviously one of the more common diseases that we encounter. The other thing is that treatment costs are also high, not only for each individual treatment, such as MRIs, surgeries, injections, other procedures, but the amount of treatment. If you look at somebody who's gone through a spinal fusion, along the way, they've had multiple visits with physical therapy, primary care, specialty surgeons, non-operative, operative, all kinds of different MRIs, injections, and procedures, and then they get the surgery. So the costs are really high. And then the third problem is that our preventative treatment options are not only low access, but are often absent to most people. So if you can't prevent the condition from getting worse, then you're going to end up with high treatment costs for a very high disease burden. And that is why MSK costs are always high. Of course, the insurance companies, the health plans bear those costs. So what happens is you get something called the MSK money pit. And what that is if you look at the typical journey of somebody who's got low back pain, especially somebody that ends up with a surgical treatment, they go through this ping pong effect back and forth from primary care, physical therapy, specialty, injections, MRIs, opioids. I'm not even listing urgent care and emergency room visits. And then you finally end up with a surgery. And so along the way, all of these things generate significant costs. And this is the money pit. And the key is, how do you avoid this trap? Because once that patient or health plan member has their first visit for an MSK condition, when they see their primary care doctor or a physical therapist or a specialist, they are now in the money pit. And it is very hard to get out of it. So, how costly is this money pit? So there was a study that was done recently, within the last year, from Stanford, and they looked at Medicare beneficiaries who had a new diagnosis of low back pain, and they divided the group up into those who ended up with surgery and those who ended up not having surgery. Now, as expected, the surgical members had higher costs. It was about $21,500 for that first year. Pretty high when you look at the average. Now, here's the interesting part. This comprised of only 7% of the total cost of care. So what that means is that this non-surgical group is 93% of the cost of care, and each person was driving $6,000 of costs per year. So think about that. We focus on trying to avoid unnecessary surgeries and everything we do, but really 93% of the costs for many of these conditions are being driven by those who are not getting surgery. And again, if you look at this money pit, right, this circle is all the non-operative costs, and finally you get the operative costs. So this is the 93%, and this is the 7%, right? Those are the patients. And so we need to start thinking about, how do we prevent this money pit from happening rather than just focusing on the surgical prevention, which is important, but not the lion's share of the costs. So how do we avoid the money pit? Well, first thing is, why does the money pit even exist? It's because there's two reasons that we are finding ourselves in this position. The first is our lack of preventative care. So if we were able to provide preventative care, we would not have a money pit to begin with. What does preventative care mean? Access to primary care, access to mental health, access to proper nutrition, positive lifestyle habits and actions, okay? And also access to exercise to keep our bones, joints, tendons, muscles, ligaments strong. If we had these preventative care options, chances are we would not have these money pits as big as they are. The second thing is, we need upstream engagement. What that means is the right treatment before unnecessary costs or treatments. So if you look at that money pit, if somebody's got mild knee arthritis, they do not need injections. They don't even need x-rays. They don't need MRIs. They don't need surgical evaluations. They don't need, actually, they may not even need formal physical therapy. They need an exercise program, right? If you can deliver that exercise program in the beginning of that money pit maze, well, guess what? You treat the person before they go through all those costs. Remember that $6,000 per person for non-operative care, right? And so that upstream engagement is how quickly you can get the person the right care and the most affordable way possible, both to the patient and to society. Remember, patients bear a lot of these costs through the copays, deductibles, co-insurance, and whatever. So, as a health plan, you have three options on how you want to deal with the money pit. Number one, you can embrace it. And what does that mean? Just do what you're doing. Status quo, right? If you're not, if you don't have a strategy for MSK care at scale, if you're relying on your in-person orthopedic surgeons like myself, who only get paid to do surgery, well, that is, you're embracing the money pit, and that's okay. But that is, you're going to keep dealing with those costs. The second option is you can just deny care. You can prevent people from getting the care they need or they're being offered, and this is what we call utilization management and prior authorization. So what that means is that we are gatekeeping the care, and we are not letting you get the care you need unless you pass certain hurdles. And we'll get into that option. And then number three is, why don't we try to reduce unnecessary care? And that's having an upstream treatment, especially multidisciplinary, because we know that chronic back pain, joint pain, whatever, is not only an organic problem with the joint itself or the spine itself, but it also is affected by mental health conditions, anxiety, pain coping and catastrophizing, access to proper nutrition, access to physical therapy and exercises, and other lifestyle factors. So if you can, and mental health being a big driver of that. So if you can help the mental health, nutrition, and the understanding of the disease condition, that is what we call multidisciplinary care. It's activating care. And if you get to those patients ahead of time in the upstream manner, you're going to prevent that money pit from happening. So those are the three options you have. As a health plan, you have three options, and these are the only three options that I'm aware of. So let's talk about option number two. Option number one, the status quo, we don't have to talk about. It's what's happening right now. You send people to it's the money pit. That's option number one. Option two is utilization management. So here's how utilization management. Now remember, as we talked about, this person is going from provider to medication to injection to treatments, and then they finally get here. Okay, they get to this point where they are told they need a surgery. What utilization management does, or prior auth, is that it blocks this process here. So the goal is to prevent unnecessary treatment. So if you're doing a knee replacement on somebody with mild knee arthritis, then obviously that's not the right treatment, right? However, a lot of times it's a blanket application that you have to submit paperwork. If you're the surgeon, this is the prior authorization. They have to submit paperwork, and then a company acting on behalf of the insurance company will decide if this can move forward or not. Now, here's the problem. Um, the patient that's dealing with this process has gone through this whole maze, and this whole maze can be 6 to 12 months or longer of time. And remember, at every single checkpoint, if they have a deductible, if they have co-insurance, if they have a copay, they've now paid money at every one of these spots. Every time they see a doctor, every time they get a treatment, an injection, or whatever, they've paid money from their cost share. Not only that, guess what? They may have taken time off work. A family member has taken time off work. They've driven to these places. So what I'm getting at is that utilization management gatekeeps it, but it's at a point that causes significant friction because this patient has now gone on this journey and invested all this time and money, only to be told no at the end when they really finally think they have a treatment option for them. So this is what utilization management is. It's really a delay or deny tactic, and we've heard those words used a lot in the vernacular. Now the question is, does utilization management actually lower costs? This is a study that came out in the American Academy of Orthopedic Surgeons annual meeting in 2025, and they looked at the costs of total knee arthroplasty or total knee replacement care in those getting having to undergo prior authorization versus not having to undergo prior authorization. And what they found is that total knee arthroplasty costs increase both in the year prior to total knee replacement and from the request date, which means there are certain costs when you have to submit an approval request. You've got to submit paperwork. Sometimes the insurance company wants more tests done. Sometimes they want people to do more interventions, like more therapy, more injections, even though the surgeon and the patient are not aligned with doing those things. And so those drives up the cost. And so what this study showed was that the impact of utilization management in a common condition such as knee replacement increases the costs before the knee replacement and also after. Okay, so again, we've got to understand that this may not be the right approach. It's certainly not on a population level. The other thing when you think about utilization management is what are the clinical aspects of delaying and denying care. This is a study out of the American Medical Association, which represents physicians from across the country, such as myself. And what they found was that 94% of the responders said that the process was associated with delays in care. Okay. And then 80% reported that patients are abandoning their treatment or their course of care because of denials. Um, that's all, those are high numbers. And again, this contributes to the friction and the growing public sentiment against utilization management. And when you look at Congress, like there are very few things that gets bipartisan support. Utilization management and prior authorization reform is one of them. And so, as a health plan, if you are doing UM and prior auth right now, that's fine. But understand that there's significant headwinds against the process from going forward. And we've seen the testimony from folks like Dr. Oz who want to pare down the practice quite a bit. So you need some other option besides prior authorization and utilization management to lower costs because that those tides might be changing. You need to be prepared for it. So let's go into option number three. We talked about implementing upstream care. Now, it is very hard to implement upstream multidisciplinary care unless you actually, as a health plan, facilitate it. Now, this is what we do at Proterra Health. We're happy to work with you as a health plan to help implement this as well and offer this to your members. But they're really in the fee-for-service infrastructure right now, which is delivering siloed care. You have orthopedics, you have nutrition, you have physical therapy, you've got primary care, you've got radiology, imaging, all those things. Everyone is delivering care in silos. There are no team-based multidisciplinary approaches because our system is not designed to do that. And that is where the innovation is coming in. So, for example, at our company, Proterra Health, we have a digital solution that really lasts 9 to 12 months with 3 months of intense care that delivers mental health coaching, education, nutrition counseling, pain coping education, social support. So we identify using social determinants screens on who needs help with nutrition and transportation. We have an MSK physician specialist overseeing the whole program. We measure patient-reported outcome measures, so we know what the patient or member is dealing with from a function, mental health, and pain perspective. We teach about the education about the condition, so that you don't always have to go to the urgent care if your pain flares up for a chronic degenerative disease. We have a cornerstone in the program on exercise therapy and physical therapy, and the whole program has coaching throughout the 3 month and beyond engagement. And so when you look at a program like this is not available right now in healthcare. And so as a health plan, you have to actually implement the program or facilitate implementing the program with a partner such as ourselves. This is what that third option is. But as we talked about, for the vast majority of patients with chronic degenerative conditions, there is some other contributing factor, such as nutrition, diet, weight, mental health concerns, pain catastrophizing, that's contributing to their level of symptoms, or even a lack of disease education contributing to. That's why these folks are going through the money pit, because they're just bouncing along without getting the proper treatment. So this is an upstream way to manage care. And if you look at the upstream digital clinic model, again, I keep talking about digital because right now, a multidisciplinary care model does not really exist at scale in fee-for-service brick and mortar world. You have to consider using digital health to get that there and to improve access for those who can't access the services normally. Now, as we talked about with UM and prior auth, this is where it acts at this point here, and it blocks treatment or delays treatment here. And this is why you get people that are so unhappy. With upstream care, what we're dealing with is at the level of initial presentation or right after they see their first clinical visit, when they generate some sort of claim. This is upstream right here. And the reason it's upstream is that we don't need to get any of those services done because we treat the person right here and we make them better. And that's how you get your cost savings. That is an upstream program and can be scalable when you use digital technologies and digital care models. So now the question is, what constitutes a digital clinic model that can actually help scale these sorts of access? You have to have three criteria. Number one is clinical grade. So you have to actually have care teams delivering care. You have to have physicians, physical therapists, coaches, dietitians. Um, that's clinical grade care. You have to actually, this is not an app, do it yourself thing. You actually have to have human intervention. And there have been good reports, especially like the Peterson Health Technology Institute report, which we've discussed before, that really show having that human interaction is far better than having a coaching or asynchronous interaction. The next is it needs to be in network. Now, from a health plan perspective, right? If you're in network, That means you're a provider group, so you can do things like, and we'll add to this clinical grade. You can prescribe medications, especially non-narcotic. You can prescribe imaging. Okay, that's the benefit of being a clinical grade clinical service. And when you come in as a provider in the network, you can bill through claims, and you do not need PM, or admin expenses. Now, when you think about it from a health plan perspective, you will be limited in rolling out digital programs if you are using administrative budgeting for your costs for the program. So if you have a provider in your network that is a digital provider, you can scale this program much quicker and you can integrate it much more clinically with your providers, especially those that are bearing risk. And finally, the connection to in-person services. So this would include surgery, PT, injections, etc. So a small proportion of patients and members will need in-person care, and you have to, as a digital program, be able to offer that. That gives your end-to-end continuum so that you're not, again, the goal is to avoid the money pit. So if you can connect directly to in-person care when appropriate as a digital program, you can avoid the big maze, the big money pit, because you're dialing in exactly where you need to be. So these are the three criteria. And then what happens, and this is data from our program, when you look at utilization of folks, this purple is the standard of care physical therapy, and then this is Protera. When you look at what happens when you use a multidisciplinary tool like Protera, you have a drastic reduction in imaging, especially plain film, MRIs. You have a significant decrease in specialty care consultations and procedures. Now, this is 90-day data, but this is all leading indicators to show how this all drives down utilization very significantly. When you have a robust multidisciplinary clinical program, not a wellness benefit tool that is a do-it-yourself app with no human interaction. So, as a health plan, the next question is, okay, if we're going to implement a digital clinic, what is the best case scenario? What's the worst case scenario? So, let's talk about the best case scenario. The best case scenario is, as you saw from the preceding graph, when you deploy a digital clinic, multidisciplinary clinic at scale, the best case scenario is that your costs are going to plummet significantly for your cost of care. And again, remember, this is unnecessary cost of care because we're improving outcomes at the same time. We have lots of data on that and we can show that. And speaking of which, right? We know that multidisciplinary care is higher outcomes, higher quality than standard siloed brick and mortar fee for service or traditional care, I should say. So you're getting better health outcomes and the member health experience is superior. Our net promoter score are typically high 70s and 80s. Typical net promoter score of health plans and health systems is 0 to 10, sometimes negative. What's the worst case scenario? Let's say you break even and you're neutral. Okay. So you have neutral costs. This will not cost you because what you're doing is, because the digital clinic is in network, you're just replacing low value care, which is standard fee for service care, the money pit, with a multidisciplinary solution in network. So let's just say it's as good as fee for service care. So then what happens is, the worst case is that the costs of care are the same. The worst case scenario is that, and again, we know this, you're still going to get significant improvement in member health outcomes and member health experience. Okay, so if you look at the risk profile as a health plan, there's really very little to no downside in implementing a digital clinic, especially if you can track these costs anyway. So you're going to be rest assured that things are going well. So in summary, we know that MSK costs are always high across all lines of business. This is due to those three factors of high disease burden, expensive treatment costs, and lack or absence of preventative or upstream treatment measures. As a health plan, if you are not really addressing this, you are embracing the status quo, which results in the MSK money pit, which is why costs are always top line for every health plan and every line of business. If you implement an upstream approach, you can avoid the pitfalls of prior authorization, especially from a long-term strategic perspective, given all the headwinds, and you can have a very low risk, high upside opportunity at lowering costs, but really driving member health outcomes and satisfaction. As I mentioned, happy to discuss more. If any of this is of interest to you, we have some more information in the comments, and good luck on your MSK journey, especially avoiding that MSK money pit.